Hello, my name is Joe Aldridge, and I've been a type 1 diabetic for 7 decades.
And I'm Cam. I'm a type 2 diabetic, and you are tuned in to the Diabetes Our Way podcast, where we discuss all things diabetes related.
This podcast, we're going to share a few laughs, and you're also going to learn a lot as far as what we've experienced over our trials with type 1 and type 2 diabetes.
But please note, we are not doctors, and this podcast is for general information and entertainment. It is not any form of direct medical advice. If you or someone in your life has or may have any form of diabetes, please contact a medical professional. Hey guys, welcome to the Diabetes Our Way podcast. I am Cam, he is Joe.
Hello.
And today we have a very special guest joining our podcast, and I'm going to let Joe introduce him.
Yes, we have. I've known Doc McKinley. I call him Doc. I know it's doctor, but I'm kind of old school. So I've known Dr. McKinley since the mid 1980s when I first moved to Bloomington, Indiana, and I was lucky enough to have him as my internal medicine doctor. And what he reminded me of was one of my first doctors that I got back in the 1960s, Dr. Stanley Bryan out of Evansville, Indiana. And he's really taught me a lot. And besides being a great doctor as far as type 1 and type 2 diabetes and every other disease out there, because I have a lot of friends and family and that have been, that been his patients. And but yeah, he really knows a lot and has really taught me a lot on diabetic care, and does it in such a way where it's you walk away from his office feeling very uplifting, not beating yourself up.
Good. And that's great because that ties in all into what we've been talking about, right, Joe? How you gotta like your doctor. So, we'll welcome Dr. McKinley. Great to have you on the podcast.
Happy to be here.
Yeah.
So,
and
go ahead. Go ahead,
No,
Joe.
go ahead, Cam.
No, I was gonna say. So, with Joe being a type 1 diabetic, I'm a type 2 diabetic. We have a few questions for you, and maybe would love to hear a little bit more about your background, though, Dr. McKinley, if you could start.
Well, I'm actually a pre-diabetic.
Okay.
So we're all on the same page, but
oh, we got everything covered.
there you go. No, I grew up here in Bloomington, Indiana, back in the 50s. My dad was a professor at IU, and my life goal was to be a high school biology teacher until I took the entrance exams for medical school, and I aced them.
Oh, wow.
And I wasn't expecting that because I didn't prepare at all. I just walked in and took it. So I thought that was probably a message from God or outer space or somewhere that I should be a doctor. So I went to medical school, and I've always wanted to be a general internist because I like variety. I don't like to just see the same thing all the time. And so that's what I tried to do. Even if I saw a patient like Joe, I looked at the other parts of Joe, not just as, Joe is not a diabetic. It's Joe, and then he has diabetes, but he also has other things. And so, I try to look at the whole person as much as I can.
Yeah. Yeah, that's a great, I think, an analogy there, Doc, because, we are human beings, and we sometimes get labeled as a type 1 diabetic or a type 2 diabetic, but there's a lot of other factors going on in that human body that diabetes kind of helps and maybe hurts with sometimes. But I like the way you said that.
Yeah, I think that's, again, internists take care of people with long-term chronic diseases. Diabetes is one of them, but there's many of them. Hypertension, lung disease, there's lots of diseases that are long-term. And so it's really important that you just don't give them a pill and say, see you in 3 months. It's more important that you get to know the person so that you know what their strengths are, what their weaknesses may be, so that you can use those parts of their personality as tools so you know how to help them. And and I think if you don't trust your doctor with all the things that are going on in the world right now, you don't trust the person who's prescribing medicine for you, then it's not going to be a very good partnership between the doctor and the patient. And I have to trust the patient, and the patient has to trust me, and it takes a while for that to happen. Yeah. And try not to categorize people and say, well, you're a quote diabetic kind of person. This doesn't work, because diabetes is different. The other thing is, I've been in practice for 40 years, and the way I learned diabetes 40 years ago is completely different than the way we diagnose and treat diabetes now. And so instead of being 2 types of diabetes, there's actually about 19 different types of diabetes. And you have to figure out first which one of the 19 your patient has before you start prescribing drugs or insulin, whatever. So it requires a little more of a careful diagnosis than it used to.
Could you expand on that a little more?
Yeah.
So, classically, the type 1 diabetics were children or people under the age of 35 who had either had a viral infection or they had an autoimmune disease that destroyed their pancreas. And so they just didn't make insulin. So the treatment for all type 1s was insulin. And now we're finding patients, for instance, with type 1 who have maybe gained some weight or become less active physically, and they're developing something called insulin resistance. It has nothing to do with the shots. It just their disease is progressing. And so some of these newer drugs that we've been reading about, the GLP-1, the GIP-1, and also the calcium channel blockers or sodium channel blockers, SGLT2s, are now being used in type 1 diabetics who are developing resistance, so that their need for insulin is lowered. And we've never done that before. We've never ever tried an oral agent or a non-insulin agent in type 1s, but we're finding that a lot of patients, especially, that insulin is kind of like it's a steroid in a way. It's an anabolic steroid, which means it helps you gain body mass, which is unwanted. We don't want people to gain too much body mass and become overweight or obese. But when that happens, on insulin therapy, we have to broaden our thinking and think, well, this person may be developing insulin resistance because of their weight gain or their inactivity or whatever, and we need to treat them more like a type 2 in some situations. And that's something I would have never thought to do, when I started practice. So that's one example of how the 2 diagnoses have kind of blurred. There's also type 2 diabetics who develop diabetes in their 40s and 50s, and they end up with complete insulin failure, and they need to be on insulin therapy later in life. We call that LADA, latent onset adult diabetes type 1. And I never saw that either in my early training, but I learned about it over the years. So you have to make sure that you go back and reassess patients. If they're type 1, they may become a type 2 in a way, and some type 2s end up being type 1 in a way. And so you have to be flexible about your thinking, and if things aren't working and the A1C is going up, something's wrong, and you need to figure out whether it's a change in diagnosis.
That,
at what point would you say that a type 2 can turn into a type 1, doctor?
So we see it in 2 different things. We see it in this autoimmune disease called LADA, where where they look like a type 2 initially, and then when their pancreas completely poops out, then they look like a type 1. But we're seeing it now in larger groups. These newer drugs, the GLP-1 drugs, are very expensive, and many people don't have them on their formulary. So when that happens to a type 2, we end up giving them insulin because it's cheaper.
Right.
But insulin's not what they need, and it makes them gain about 15 more pounds. And so, if we, in an ideal world where insurance companies paid for whatever the doctor ordered, I wouldn't give them insulin at all. I'd give them one of the newer drugs, and to see if that would have some effect on their insulin resistance. And so but unfortunately, in our economy, insulin is now cheaper, and so people are using it because they just can't afford the $2,000 a month for Wegovy or one of those fancy things,
Right. Yeah.
and so that's being caused by our healthcare system. Patients are not getting the right drugs because of finances, and it shouldn't be that way, but that's the way it is.
Do you
And
think
so
that contributes to people who will just go ahead and pay it without the insurance, so it makes it harder for those diabetics to get that medicine?
yeah, all the movie stars that want to be a little have smaller waistlines for their weddings, kind of junk. There's also something called the gray market. You probably have heard of that, but the gray market is, let's say a new drug comes out, like one of these Ozempic type drugs, and somebody goes out and buys up all the Ozempic that's out there in cash, and then triples the price for the patients who really need it, the diabetic patients.
Mm-hmm.
So that's the gray market. That's happening in several areas where entrepreneurs are buying up all of one drug so that they can resell it at a higher price. That's another finance, and has nothing to do with the insurance companies. That's just
Right.
somebody who's trying to make a profit.
Can I add to that, though? And I don't always agree with this gentleman, but everything else. But my understanding is Mark Cuban actually has he's done that, but he's actually selling it at a lower cost. Do you know
Yes.
anything about that?
Yeah, so I'm a senior citizen myself now, and I'm on some medications, and so I shopped around to see whether I would get a better deal with Part D Medicare or Mark Cuban, and there are some situations where his are actually cheaper than I can get it through my own insurance. The other thing that's not publicized is if you go to see a pharmacist, and this happened to me with my father. So I go to you probably heard the story, but I went to the pharmacist and I said, how much is my dad's medicine? They said, it'll be $87. And I said, that's with insurance, right? And he goes, yeah. And then he kind of winked at me. And I said, well, what's that about? He says, well, if you give me cash, it's $13.
Yeah.
What? It's cheaper with cash than it is with my dad's insurance that he's paid for? They go, absolutely, but we're not allowed to actually tell you that unless you ask. I said, well, how could you not be allowed? Pharmacist says, we sign a contract with the drug companies. We promise not to tell them if it's cheaper to pay cash.
Mm-hmm.
Because that, if you use the credit card, it goes through the middleman, and they get their little cut of the deal. So I was just dumbfounded when I found that out, and it's true of my own medications. Some of my own medicines are far cheaper if I just give them $3 or $4 for a drug that'd be $18 with my Medicare that I'm paying for. So stuff like that just drives you crazy.
Yeah, Doc told me about that too, and I've actually used that where I paid cash. And the pharmacist, it was funny watching the clerk go back to the pharmacist 2 to 3 times. And I said, no, tell him I know what's happening here and that I'm paying cash for this.
Oh, wow.
And instead of it being $45, it was $6.
There you go.
Wow.
And so,
Well, the pharmacist should be taking our side,
right.
right?
Right.
But they're corporatized. In the old days, we had independent pharmacies. They're all gone. And those guys would take care of the patients, and they would give you counseling about the medicine, and they would also make sure you got the best price. And it's not that way anymore because of, the big box stores.
Oh, wow.
Well, that's interesting because Cameron's dad, my brother, he was basically a manager at a big pharmacy box store. We won't name the name, but he was, and he would tell me some of the horror stories.
Oh yeah, yeah. So there's a lot of inequity in that system, and the middleman, the benefit managers, they do a good job of maintaining formularies, but they take a cut, and whenever there's a discount for a drug, that discount was intended by Congress to go back to the patients. But instead it went to the PBMs, pharmaceutical benefit managers.
Very
and I think that should be outlawed.
Yeah.
Because it's not the intent of Congress. It's being subverted. And so there's a lot of things like that are unfair. And kind of as a doctor, it makes me mad because I'm trying to help the patient, and then there's all these other people who are kind of working against me in a way. And so it's not a good system for patients.
Mm-hmm.
You mentioned a couple things there with the 19 different types of diabetes. Now, and I mentioned this in a podcast. When I first got diabetes back in the late 1960s. My wife and I, and she's in healthcare and stuff like that. She still thinks this isn't true, but I was told that my life expectancy was about 25 years back then as a type 1 diabetic. Because we had no, blood check like a Freestyle Libre or nothing like that. It was all by feel.
Right.
And now I think especially type 1 diabetics, we can live so much longer.
Oh, yeah.
And I'm wondering, is the body adjusting, or is the disease adjusting in the body to make these different forms of diabetes happening with people?
Well, I think, part of it is we were just ignorant before, and there were always different types, but we just didn't recognize them. And so we would try a drug and it wouldn't work. We just try another drug until we found one that worked. But really, if you think about that, well, why would that drug work in you and not in you if you're both diabetic? And so there must have been differences. Mm-hmm. The other thing is, as far as, your lifespan, a lot of patients back in the early days died of diabetic ketoacidosis because we didn't know what we were doing, and they would come in, the sugars would be 1,000, and they would have a stroke and just die. And nowadays, except in the country, in Russia, that's still happening. Children are dying of type 1 diabetes from the ketoacidosis. But as you know, the major complications of diabetes are macrovascular, that's large vessel disease like hardening of the arteries and stroke, heart attack, that type of thing, and microvascular disease, which is the neuropathy, nephropathy, retinopathy. And we know that tight diabetic control definitely reduces microvascular disease. So it definitely reduces the incidence of retinal disease, kidney disease, and neuropathy. But it didn't have a direct impact on heart attacks and strokes. So now the number one cause of death in type 1 diabetics is the same as it is in type 2s, heart attack and stroke. And so we need to, that's why we need to separate those out from the diabetes. And it's now automatic that if you're diabetic type 2, you need to be on a statin drug, regardless of your cholesterol level. It doesn't matter what it is. It should be 50% lower than whatever it was before you start taking it. That's not the way I was taught. I was taught that if it was really, really high, I would treat it like anybody else. But we're much more aggressive about treating vascular disease in diabetic patients than we used to be, and that's what's saving lives, is preventing the first heart attack or stroke, which then leads to disability, leads to bed sores, on down the line. And so I think almost every person that I know of that's type 2 diabetic should be on a potent statin drug, and there's a lot of people who are kind of anti-statin out there also. But the benefit far outweighs the risk of taking a statin. I think it's interesting. It reduces the risk of heart attack by 2,700%.
I actually
think about that. That's huge.
I actually stopped taking my statin though. But then again, I've done a lot of I've eaten better, working out, losing weight. I've seen my blood sugars stay in the normal range, and I was on, metformin, glipizide, and Jardiance, and then Astrovision, which was my statin. Right. And now I'm completely off of those right now because I'm still on Trulicity. That's the only one that I am taking right now.
And I have a lot of patients who, maybe 10% of my patients just could not take them either because it made them feel bad, tired, or gave them muscle pain, etc. But it's hard to, it's just hard to. I still encourage people to take it if they can.
But I've heard that's the statin is hard on the liver, though. Is that correct or no?
No. In fact, this year they dropped the recommendation. We've always checked liver functions when we start somebody on a statin, and we check it after we've had them on it a while. That's been taken away. The risk of developing a liver toxicity from statins is on the order of 1 in 6 million patients.
Oh, wow.
So it's very rare. It does happen, but it's very rare. And still, the benefit outweighs the risk. The other thing is, if you're going to read about this, you should read about something called the pleiotropic effects. That is, These are the effects of statins that have nothing to do with cholesterol lowering. It has to do with turning off inflammation in your blood vessels. So it's pleiotropic, pleiotropic. If you read about the pleiotropic effects, that makes most physicians feel encouraged. They should at least bring it up and talk about it to their patients. And again, you're not alone. A lot of people don't take their statins, and and I've been on a statin since I was 40 years old. And my story was that I went to see my doctor, and he said, Lee, your cholesterol is really high, but you're a jogger, you're skinny, you don't have any family history of heart disease, so you don't need to take this pill. I said, okay. And so then about a month later, somebody called me from Indianapolis, a friend of mine, and said, we want you to do a coronary calcium score on your heart. I said, well, what's that? He says, well, we're going to take a CT of your coronaries and calculate how bad your arteries are. And he says, I know that you're very healthy, so I want you to be my normal patient, so I can compare you with other people. So I went to Indianapolis, and this friend of mine, he's a radiologist, he did the CT, and then he came out of the room, and he had this funny look on his face. He says, well, you're not going to be my normal patient. I said, why? He says, you've got calcium all over your coronary arteries. He said, I don't understand, but he says, you've got coronary disease. So I went back to my own doctor, and I said, what do I do? And he says, well, you shouldn't have had that test in the first place because I didn't order it. And then typical doctor, right? Yeah. And then he said, but now I'm going to have to do a stress test on you just to make sure that you're not going to keel over and die or something. So he did a stress test on me, completely normal. I went like 12 minutes on a treadmill, no problem. And then he repeated my cholesterol. My total cholesterol was about 400. He said, but this you have a normal stress test, and I don't know what to make of this coronary calcium score thing that you had, but he says, you don't have to take anything. So I talked to my wife, and she says, we have a mortgage, so you're going to take something. So I said, okay. So I took the lowest dose of the mildest statin there was, and my LDL cholesterol dropped from 260 to 70 in 1 month.
Yeah.
Wow.
And I was already on a vegetarian diet. I mean, I couldn't do any better with my diet. So I knew that has to be hereditary or something. I mean, why would it be so high and I don't eat that stuff? Yeah. So I've been on a statin since I was 40 because of that. Just because, my wife, until my mortgage
Right,
was paid.
yeah. Yeah, one thing about my doctor that I love is that we're always talking and we're always saying, hey, what would work? He's very encouraging me, before he tries to put me on anything, let's try like the normal things like diet, exercise, and things like that. And, I've been talking to him all through this process about, how I've lost all this weight and what I'm eating. And he's like, okay, now we're going to wean you off this, you're going to do that. So,
That's good.
What's your approach? Are you the person, and how do you not to say, let's try this normal things versus like, hey, let's get you on a medicine? And how do you not become discouraged with your patients when they're not listening to what you're saying?
Well, I think I go back to if I have a relationship with the person, I have a little more understanding about why they feel that way. So obviously, I would honor whatever wishes you have. It's not my body; it's your body. I'm just giving you advice. But sometimes patients ask me for things that I did not agree with. I had a patient who wanted me to give her an infusion of vitamin C intravenously in my office once a week because she read an article about it. And I thought about, well, it's probably harmless. But if we give her injure her putting an IV in, or she gets an infection from the catheter, and there's no proven benefit for vitamin C, then what am I doing? That's not the right thing to do. So I have to tell patients if I'm uncomfortable if they ask me to do something that I think is more harmful than beneficial. But again, I try to defer to the patient as much as I can because it's their body, it's not my body. And, but as long as they understand the risks and the benefits. But, doctors are trained, we're trained to basically honor the risk-benefit ratio Because if risk is greater than benefit for anything, cancer or whatever it is, we probably shouldn't do it. Because it's hard to justify that if the patient has a complication. So I had a patient, he said, he wanted me to do something, and I said, well, I can do that. He says, well, I won't sue you. I said, well, no, you'll be dead, but your wife will.
That's right. That's right.
No,
was he an attorney or married to
No.
an attorney?
No, he wasn't an attorney, but it has to be a partnership between you and the doctor. And if you don't feel like it's a partnership, if I'm just telling you what to do all the time, that's not going to work.
Right.
Yeah.
And by the same token, you can't tell me what to do all the time. We need to be kind of in agreement. And I think that's the real key is, that you honor each other. You honor my knowledge and I honor your knowledge about yourself. Mm-hmm. And I think that enables you to have trust with each other.
Yeah.
I was going to tell you, I know you put me on that statin with my high blood pressure medicine back then, and then they wanted to, I know we're not supposed to disclose medical information, but it is me, so I'm okay with that. And, but then they wanted to take me off of that, and I got really upset with that because I was so used to that other, the HCT and everything else, Ibosart and HCT.
Right.
I really loved that, and I felt better than what they put me on. Now, I'm still on a statin, but I'm now taking 2 or 3 different drugs instead of just taking one.
So
And-
there's an emerging list, you might look this up too, but there's a list of drugs that we didn't know before that make diabetic control worse. One of them is the hydrochlorothiazide that you mentioned. It's a diuretic. We've used it for 100 years for blood pressure control. It works very well for blood pressure. But if you're a type 2 diabetic or if you're a pre-diabetic like myself, it doubles the risk of hyperglycemia, of high blood sugar. It doubles it. And it doubles the number of people who go from pre-diabetes, like I have, into real diabetes. And so then is it worth lowering the blood pressure to let that sugar go up that high, or is it not worth that? That's a judgment call. But there's a whole list, besides steroids, which are the worst, diuretics, and there's lots of chemotherapy agents that definitely work against your body's control of blood sugar. And so your doctor just needs to be aware of that. And I've asked several patients who were having trouble controlling their A1Cs if they would consider going off the hydrochlorothiazide, the diuretic, and use something else for their blood pressure because it was making their diabetes worse. And some said yes and some said no. So, as long as you advise the patient of that and you understand where they're coming from. But there's a growing list of medications out there that work against your body's normal insulin delivery system.
Yeah, one of those was what I've heard is glipizide, and how glipizide actually has more of a negative effect on your pancreas as it produces insulin. Like it kind of basically doesn't let your
So it stimulates the production of insulin by your pancreas. That's how it works. And there are people who believe that after years and years of taking glipizide, that it keeps beating on your pancreas, and your pancreas finally just gives up and stops making insulin, and that we've kind of worn the pancreas out. And it's not a go-to drug anymore. It's like it's the third or fourth option now in patients who have diabetes. It also increases cardiovascular events, whereas these newer drugs, the GLP-1s and then the GIP and the other SGLT2s, they reduce cardiovascular risk. Also, the newer drugs reduce the risk of renal failure, independent of their effect on diabetes. And so there's lots of other, and those are what we call pleiotropic effects. These drugs were invented for sugar control, but we're now using them to lower cardiac risk, which is what's killing our patients. It's not that diabetes is killing them with heart attacks, it's the other things. And so we're using those drugs now in patients who don't even have diabetes because it reduces the risk of stroke and a heart attack.
Where do you
go ahead.
Go ahead, Doc.
That was it.
Where do you see the diabetes train going in the future? I mean, I'll probably be dead, at my age, but I mean, where do you really see this happening? I know you and I've had coffee together, and we talked about, you know, uh, is there going to be a cure, especially for maybe type 1? But with all these different forms of diabetes now, I'm sitting there going, well, I don't know. I mean, what could be developed to really make a cure?
So I think, these newer drugs that are coming out now, the one from Lilly especially, and some of the other ones, people are on the bandwagon because it causes weight loss, and that's really what they care about, is how they look in a bikini, but it turns out they also have these other beneficial effects. And so, they're being overused by people who probably don't need to take them for cosmetic reasons. But I think the future is treating the disease, which one of those 19 types of diabetes. So we should be better at figuring out how much insulin resistance does my patient have, whether it was caused by their diabetes or whether it was caused by their insulin. Number two, how much insulin are they making on their own? And do I need to add some, or are they making enough that they don't need insulin? And so we need to continue, like every 2 or 3 years on a patient, we ought to recheck those numbers to see what kind of diabetes they have. It's going to be changing over time. And if you just decide they're type 1, and you stop thinking about it, then you're going to be wrong for that patient when 10 years from now. And so I think the answer is going to be like cancer. There's not one cure for cancer. There's a cure hopefully for each type of cancer, and there's hundreds of types of cancer. It's going to be very similar to that. The emphasis we put on shaming patients about their diet turned out to be a disaster. It made our patients feel bad when we yelled at them about their diet. It made us feel bad, and it didn't work.
Yeah. Could you expand maybe on that with, because I really believe, and I've gone to Australia, I go to Italy, I've gone to Prague and stuff like that. When I go overseas, my diabetes is run so much, my sugar levels are so much better than the stuff, or I like to say sometimes, the crap I eat in America.
Right. Well, the history of diabetic foods, and quote dietetic foods, was they took the sugar out and they replaced it with lard.
Yeah.
They put fat in there, which they thought, well, it'll have less sugar, which means it'll make your sugars go up less. But in the long run, you got more calories. And so diabetes is not about sugar, about how much sugar you eat. It's about how many calories you eat and what kind of calories. And we know that the only diet that's proven to make you live longer is the Mediterranean diet, which is what they eat in Europe, right?
Yeah.
The low fat, low carb, high fat, high carb, all those diets are worthless. They have shown no benefit whatsoever for diabetes, hypertension, or heart disease.
Yeah.
So the Mediterranean diet is what we probably should adopt, but it's hard for people that are focused on the American diet, and look what we've done with our schools. I mean, our kids are eating pizza for lunch instead of what you and I had to eat, which was, we hated it, but it was probably better for us.
Yeah.
Yeah. So I think, it's a cultural thing, and I think that's why people resist going to the Mediterranean diet. But you've noticed it when you go there. I mean, you're eating a different diet, and what's in the food is really important. What other things? So whole food, fruits and vegetables, we know, are completely different than applesauce, or something that's been,
processed
exactly.
food. Yeah.
What are
and we don't even know what the benefit, where they're coming from. It could be in the skins or the seeds of the things we're eating. We don't even know why it's better, but we know it's better.
Yeah. I always kind of chuckle too. That is about, I never could stand diabetic candy, but when you really look at like diabetic candy and sweeteners and stuff like that, they've got fructose in it. They got all these artificial sugars in there.
Oh, yeah.
And they're almost worse than eating regular honey or something like that.
Right, exactly. No, when you eat something that's 0 calorie, they did a study a couple years ago where they gave people dietetic candy and their sugars went up, just like they were eating sugar. Because some of this comes from your brain. Your brain senses that it's sweet, and so it kind of reacts. And so, it really didn't help. And as you know, the number one cause of liver failure in Indiana is not alcohol cirrhosis, it's fatty liver disease. And insulin drives fructose into the liver cells where it turns into a plastic and they can't get back out. And so then your liver fills up with this crap and you develop cirrhosis, liver failure. And
so what I hear you saying is avoid all this fructose, sucrose, all these kind of sucrose, anything with the ose in it.
well, except for natural glucose, which is half fructose, half dextrose. But, it's the high fructose corn syrup that is
The
dangerous.
corn syrup.
High fructose corn syrup.
That gives my wife's migraines.
Yeah, I mean, it's toxic. And, it's interesting, the liver, if you give the liver a bunch of sugar that comes from, let's say, eating an apple, it absorbs what it needs. And if the liver's full and doesn't need any more, it stops absorbing the sugar from the liver naturally, even without insulin. If you give somebody high fructose corn syrup, the liver sucks all that high fructose up regardless of how much is already in there. And so there's no gateway, there's nothing to block the natural way of the liver protected itself. It can't block it. And if you look in the food that we eat, almost all of it's got high fructose corn syrup in it. And, it saved the manufacturers a few bucks to use that rather than natural cane sugar or whatever. But in general, cane sugar, calorie for calorie, is much healthier than high fructose corn syrup.
Yeah. I mean, for me with my coffee, because I have to have my coffee, but I drink it black, but I have like 2 tablespoons of granulated, sugar, and that's fine for me. And for my diet, I'm on more of a higher protein diet, and then I love to eat my fruits and vegetables. And it seems to be, I've been in a caloric deficit because I've been trying to get this, 33 pounds so far, which has been great.
Wow.
So at what point would you say is there anything that you think that diabetics should be, they should get this in their system on a daily basis to help with their blood sugar levels?
So again, there's a trade-off. There's a short-term benefits, which is if you eat less sugar, your blood sugars are going to be lower. But it's hard to sustain that kind of a diet for forever. And the long term, so if if you have a mortgage, like I did, and you're thinking long term, the only diet that's proven in diabetics or non-diabetics is the Mediterranean diet. All the other diets give you no benefit long term at living longer, one day longer. And so it depends on which one you look at. In general, the Mediterranean diet is good because it's mostly fresh fruits, vegetables, nuts. There's in Europe, a piece of beef is about $25 for 4 ounces of beef in Europe. So they don't serve much of it because it's so darn expensive. Whereas fish is a little cheaper in Europe, and it turns out that fish is a better source of protein probably than beef. And again, there's something in the processing when they make sausage and bologna and all those things that we love, and pepperoni. There's something in that process that makes them more toxic to our system, and they actually trigger inflammation in our blood vessels and cause our arteries to constrict a little bit, and that's not a good thing.
Yeah.
So I think it depends on your goals, but the long-term play is to be on a Mediterranean style diet. It doesn't have to be perfect, but again, if you could eat Mediterranean 2 or 3 days a week, you don't have to get rid of any of the stuff that you normally do. I eat less red meat now than I did 10 years ago, partly because it's hard on the environment to raise beef and pork, and we haven't figured out how to get rid of the sewage that comes off those farms very well. And I don't think that there's any benefit nutritionally of those over beans and fish, which are my primary source of protein.
Right. Are you seeing more people come to your office, more younger people with pre-diabetes or even type 2? And at what point do you say you label someone as a pre-diabetic?
So there's three different ways of assigning you, whether you're normal or not. So the A1C is the easiest. So if your A1C is less than 5.7, you are quote normal. But I can tell you retinopathy starts when your A1C is above 5.5. So we don't know if there's a cutoff there. And really, the cutoffs are artificial. Doctors make up these cutoffs. If you're between 5.7 and 6.4, you're a pre-diabetic. If you're above 6.4, you're a diabetic. The old way of diagnosing was to use a glucose tolerance test. That is to give somebody 75 grams of glucose to drink and then measure what happens to their sugar after they drink pure sugar. And if your sugar 2 hours after that drinking that is over 200, that's another definition for diabetes. There's also a difference between impaired fasting glucose and postprandial after meal hyperglycemia. They're different animals. So some people, they wake up with a high sugar, but it doesn't seem to go up much after they eat. Other people wake up with a normal sugar and their blood sugars go up only when they eat. So it's kind of a weird, three different patterns there. And so it's helpful to find out which one of those patterns your patient has so that you can tell them about when to take their medicine, also which medicine might be more healthy, and also what's going to prevent them from having hypoglycemia.
It's interesting you say that because I wake up in the morning, my sugar doesn't go up, and I'm drinking a cup of coffee with honey in it. It's Manuka honey from New Zealand.
Wow.
But basically my sugars go down.
Right.
And I'm just sitting there listening to podcasts, Bible in the Year, stuff like that. And I'm like, why is my sugar going down?
So that's your pattern. Of course, in your case, if you take insulin, that has an effect on your long-acting insulin has an effect on that morning sugar. So
my Lantus, yeah.
Yeah, and so for most doctors, if patients are waking up with a blood sugar of less than 140, we tell them to back off on their nighttime dose of long-acting insulin. But if you're not on insulin and you have that pattern, then it tells me a little bit more about what kind of diabetes you have. And so that would be a typical pattern of a person who has postprandial hyperglycemia. That is, they have trouble making insulin in response to a meal. But during the night, their pancreas makes enough to get them through the night without their sugars going up in the morning. So it kind of helps me to understand a little more about what their defect is, what the defect is in their system, so that I can use the right medication.
Yeah. Well, what about those people who, they eat and then they wake up in the morning and their sugars are like in the 200s, almost 300s?
Right.
Like, what would you classify them as?
So if they're not, so those people have impaired fasting glucose. They wake up with a high sugar, and if they're not on insulin, it is an indication that their liver is not receiving enough insulin during the night. And again, there are certain medications that would help that, and other ones that would make that worse. So waking up with a high sugar, again, if you're not on insulin, is usually an indication that you're not suppressing that during the night. Your liver at night when you're fasting releases sugar from its storage, so that you don't get low sugar. So we all don't get low sugar during the night when we're sleeping. But it takes a little bit of insulin to control that. And so it would tell me that you may have a deficiency of insulin secretion at night.
Okay.
What it tells me is that Cameron's eating 2 slices of pizza at 9 o'clock at night.
No. That was the old Cameron. Yeah, the old Cameron probably was doing that. And that's where I was at. My trends was I would wake up in the morning. I'm like, hell, why am I so high? And
there's another thing that's called. Have you ever heard of the dawn phenomenon? DAWN.
Yeah.
So the dawn phenomenon is that your brain wakes up about 5 in the morning, but it doesn't wake you up until about 7. And between 5 and 7, your brain sends a message out, hey, Cameron's going to wake up in a couple of hours. Let's rev this system up and get ready for him. So when he jumps up, he's ready to go. And one of the things that they do, that it does is release sugar in response to cortisone. So your own body makes cortisone, and it does that to wake you up in the morning, and that makes your sugars go up. Wow. And so that tells me you have a very prominent dawn phenomenon. Mm-hmm. And it's just, it's another type of diabetes that's triggered by that. You might also notice that your sugars go up with that condition if you're under stress. So if you're sick, your sugars may be higher.
Yeah.
Even emotional stress can make your sugars go up if you have that type of a system. So it might be helpful to check your sugar occasionally, when you've eaten like way too much, or when you've had under a lot of physical stress, or if you've got a high fever, just to see what it's doing during an illness.
Yeah.
I
Yeah,
know.
I'm fortunate that I don't have that problem anymore. Everything. My
Good.
problem now is it goes a little too low,
Ah,
and
okay.
in the probably in the 60s, somewhere around there. But then me and Joe have had this conversation about our glucose meters and how they can be inaccurate, and then I usually test my blood, with a finger prick on there, and it's usually like 30 things off, 30 points off there. So, but it's actually been really good now. So
Good. Well, the way we treat that, if you were on insulin, the way we would treat it would be to say you need to take a pure protein snack at bedtime,
Yeah.
because that tends to kind of even out the sugars, as opposed to a sugar bolus, a bunch of sugar, which means go up and then back down. A high protein snack at night, like peanut butter or something like that, would be good.
yeah.
Hey, could I? You did something for me way back when, as a type 1 diabetic. You said you calculated based upon my age, I think it was, weight and height and stuff like that, that I should not inject more than 38 units of insulin a day. Fast acting insulin, long acting insulin, that type of thing. Because if I was a normal person, and everybody knows that I'm far from normal, but I would produce about 38 units of insulin a day. Could you go over that calculation and that? Because I just thought that was amazing, and I still do that today. I'm usually only injecting about 30 to 32 units a day.
Well, and when you see somebody who's that sensitive to insulin like you are, that tells, because I've got patients who are on 300 units a day. And, there's other issues there. But the reason, if you take a person who's, let's say, just absolutely perfectly normal person, and you removed their pancreas, you just took it out for some other reason, because of cancer or something, we know that it takes about 0.7 units per kilogram of normal body weight for your height to satisfy the needs of your body. So if you take that 0.7 times your weight in kilos, what your ideal weight should be, not what your actual weight is, that gives you kind of a baseline. And that's kind of what doctors use to kind of guesstimate when they first start a patient on insulin about how much are they going to need. Now, if you gain 40 pounds on me and your sugars start to go up because you're bigger, your need for insulin is going to go up because you become more insulin resistant as you get bigger. And we know that intra-abdominal fat is one of the major causes of that resistance. And that's where most of us gain our weight, is in our midsection. That's just kind of the way we're made. It's very genetic. So I think, but I only use that number that I gave you, Joe, when I first initiate the care. Then after that, I base it on their blood sugars.
Okay.
What is it before meals? What is it after meals? Are we covering the meal adequately? And then what is it when you wake up in the morning to satisfy your liver? So I only use that initially in most patients, just to kind of, and right now we're in a time of over insulin use. Doctors are just giving more and more and more insulin to people as they get bigger and bigger. And it's just kind of a vicious cycle. You get bigger and then your sugars go up and you give them more insulin and they gain more weight, and it just keeps going. And it's not a healthy cycle. And unfortunately, a lot of doctors it's a knee jerk. Your sugars are up, let's up your insulin. And, it's not the right answer. And probably the answer for some patients is to go back and reassess what kind of diabetes they have and what their pattern is, and then start over. That would be what most doctors what we should be doing.
Yeah.
But, it takes a lot of time to do all that. And a lot of doctors, you've got maybe 7 or 8 minutes with them, and then next patient. And so it's difficult to go through all that in 7 minutes.
Mm-hmm.
Well, the other thing I noticed too, and if anybody's listening that's a hospitalist, I know I've always kind of, with the new healthcare systems and stuff like that, I really feel the hospitalist only gets to know you for an 8-hour or 12-hour shift. and then they don't really know because they're just looking at that. And I
Right.
really feel like as a diabetic, especially a type 1 diabetic that's been had it for a number of years, I miss not having my regular doctor like you or Dr. Teague be able to walk into the hospital and say, hey, I know what's happening because I've known this guy for 2, 3, 10, 15, 20 years.
Right. And I think, we know from lots of studies that inpatient diabetic control is lousy compared to outpatient in general. They just, they're worried about your pneumonia or whatever they're worried about more than probably the diabetes. And it's also a higher risk for hypoglycemia. So most of the hospitalists don't want to take a chance on a low sugar. So they tend to let the sugars run higher. And the other thing is that the inpatient doctor can, if he or she takes time, look in the chart at my office notes and see what I was doing with you, because you can learn from the outpatient record, but it's not a requirement for your inpatient doctor to even look at your outpatient chart. But
I didn't know that.
It should be.
Wow. Yeah.
Because, like I had a patient, this is just a quick story, but I had a patient and the hospitalist called me and he said, Dr. McKinley, we've admitted your patient 3 times. She keeps vomiting. We've scoped her stomach. We've done all these tests. We can't figure out why she vomits. And I said, well, she drinks a 5th of whiskey a day. He said, no, it says right here, she says she denies alcohol use. I said, okay, look at my chart. Look at the blood alcohol test I did last week at 10 o'clock in the morning. It was high. Okay, so I know she drinks. So then he went, oh my gosh, that explains everything. I mean, yeah. So, you gotta look at other doctors' notes so that you get the whole picture. And I think that's something that inpatient doctors are doing better with currently, but in the past they just kind of started from scratch. And and like you said, you can't really do that with a diabetic patient. You need to know what works and what doesn't work.
Mm-hmm.
Yeah.
Yeah.
And,
well, I know we're running short on time, but
I got one more question for you, Doctor.
Okay.
I'm gonna let you go. 'Cause I know thank you again so much for being here. I'm learning so much. With people who are working out, right? They say that any glucose that's been stored up, that's the first thing to go. So when does that actually start replenishing back? And I guess it's probably not beneficial for any diabetic to go work out when they're fasting. They at least need to eat something before.
Right. Especially something with protein in it, again, because it kind of it releases more slowly. If you eat something that's pure sugar, which a lot of runners do, they eat a whole 3 bowls of spaghetti and they kind of overdo it. Mm-hmm. It does take an hour or so for the food to get into your system. And then once your blood sugar is depleted, then your liver starts dumping sugar into your system. It takes about an hour for that to happen. So there's 2 responses depending on whether you're doing a short-term sport like a sprint or whether you're doing a marathon. It's kind of a different pattern because in the marathon, you've got more of a long term there. You're going to use up a lot of your glucose stores. So I encourage people to eat some carbs the night before they work out and to eat protein either an hour before or 2 hours after. And there's 2 reasons for that. Is the protein is an anabolic thing. So if you're working out and trying to develop muscle, protein actually stimulates muscle growth. Mm-hmm. And weightlifters want that. That's why they're doing the exercise.
That's what my
the other thing is it evens out the blood sugars, And so, and a lot of people, who have been on diets, they don't just lose fat, they lose muscle. And we're trying to have them not do that when they're losing weight because the muscle is really good for you. There's kind of a saying among doctors, it's better to be fit and fat than to be skinny and weak. So it's much better to be overweight but be fit and have muscle than it is to be skinny and have no reserves. And people who are overweight but fit live longer than people who are skinny and have no muscle.
There you go, Cameron.
There you go.
So, hey, also, too, you're not supposed to really work out if your blood sugar's above a certain level. Is that correct?
If it's very high, especially if you're type 1, because then you're at risk of going into acidosis while you're exercising. And some people's livers stop dumping sugar at a certain point with exercise because they're working really, really hard. Mm-hmm. And the body's trying to keep the heart going and the brain going, but it lets everything else kind of go to pot. So yes, you can, and but most players, their biggest fear is to get a low sugar during an athletic thing and embarrass themselves, and so they eat all the sugar, so they run high.
Yeah.
Not a good thing in the long run, but I understand why a 19-year-old guy would do that.
Right.
Not wanting to look
Well,
stupid.
I did that back when I played high school tennis and everything
Exactly.
else. And because I'd have reactions right on the court and forget what the set score was.
It's human nature. I think, eating some protein with that sugar is probably a better idea. That way it kind of, again, it evens it out. It slows down the gastric emptying so that the sugar doesn't hit you all at once. It kind of does it over time. And that's also helpful for athletes.
Sounds like
Well, I know our time's kind of short here, but Doc, we'd love to have you back on and everything else, and we we really appreciate all this information. I learned so much, just listening to what you were saying, and if our listeners have questions or whatever, you can always email us, and I'll let Cam give all that information out and everything else. But once again, like I said, I was fortunate enough to have this guy be my doctor when I came to Bloomington, Indiana.
Well, thanks, Joe. Appreciate you guys. Thanks, Cameron.
Yeah,
Okay.
thank you, Doctor.
Okay. All right. Have a good Mediterranean dinner.
I will.
Okay. I tell Maria hi.
Wow, that was really interesting stuff there.
Yeah.
Yeah,
Yeah.
I learned a lot for sure.
Very, a smart, intelligent man, especially if he aced the medical exam and didn't study.
Exactly. Well, wow.
And he's one of the most personal guys you're ever going to meet.
Yeah, he was very personable. Ton of information. If you have any questions, anything that Dr. McKinley talked about, email the podcast at diabetesourway@gmail.com. Of course, we're going to promote this a little bit before we post it, so I'll try to get it posted maybe next week. Let everyone enjoy the nice 4th of July holiday.
Yeah.
Joe, you got any big plans for the 4th of July?
No, just celebrate America, one of the greatest countries there is, and we're just fortunate to be here and be in America.
Amen. I couldn't have said it any better myself.
Yeah.
So
and thank all the men and women service people like your brother and my nephew and everybody that's now serving to protect this great nation, and all the first responders and police officers and firefighters.
Absolutely. Thank you all very much. So should we do our sugar check?
Yeah, we should.
Yeah, we should have done our sugar check with
Well, maybe not.
So I am at 116 right now, so doing great.
I'm at actually 163. So
Oh wow!
I had a late lunch.
Oh, that's the highest that you've been on the show so far.
Yeah. No, had a late lunch, and it was a wrap from Penn Station.
Okay.
So
yeah,
and actually, it wasn't the Mediterranean; it was the Italian. So maybe that was the problem. And
well,
I probably underestimated the carbs that was in it. So
yeah.
Probably missed it by a unit.
Yeah, absolutely.
1 unit. So
all right, guys. Well, thanks for tuning in, and we're going to keep the guests coming. I think we got another guest coming up in our next podcast. So thank you, Joe, for providing the guest today. I will. I'll try to work on my end to get a guest.
I got two other ones that want to join too.
He's got it locked in. So
yeah. Well, it's great when you meet a lot of people.
That's right.
Yeah.
All right, everybody. We'll have a great 4th of July. And thanks, Joe. Have a great 4th of July yourself. And
you too.
Thanks for
tell your mom and dad hi.
I will. Tell Lisa and them I said hey too.
Okay. Take care, Cam.